Single complete dentures. This presentation has been prepared by Musayev Emin, docent of Ortopedik Dentistry Department. Introduction. The single complete denture opposing all or some of the natural dentures isn't an uncommon occurrence. Several causes for the loss of teeth, incidence of tooth loss, maxillary and mandibular single complete denture should be given for many reasons. Several difficulties are encountered. Definition. The making of a maxillary or mandibular denture as distinguished from a set of complete dentures. GPT-1. A single complete denture is a complete denture that occludes against some or all natural teeth, a fixed restoration or previously constructed removable partial denture or a complete denture. Indications. A single complete denture may be desirable when it's to oppose any one of the following: natural teeth that are sufficient in number not to necessitate a fixed or removable partial denture, a partially edentulous arch in which missing teeth have been or will be replaced by removable partial denture, a partially edentulous arch in which missing teeth have been or will be replaced by fixed partial denture, an existing complete denture. Diagnosis and treatment planning. For proper diagnosis and treatment planning, evaluate edentulous arch, reni sulcus, palate, mucosa, ridge, severe undercuts, tongue, lips, temporomandibular joints, mouth opening. Dentulous arch, number of teeth present, position of teeth, condition of teeth, endodontic condition, restorative condition, condition of existing restoration, and periodontal condition. Various combinations of single complete denture. Mandibular denture to oppose natural maxillary teeth. This situation occurs due to surgical trauma, accidental trauma, greater challenge than maxillary single complete denture. Factors which particularly have to be evaluated for this scenario are preservation of residual alveolar ridge, force of jaw closure is greater with opposing natural teeth than with a complete denture. When the force is more, the pressure is greater and bone resorption followed. Stability of mandibular denture is very difficult due to tongue movements. Denture movement will increase the pressure and stress on the mucosa and bone, which is detrimental to comfort and preservation. Minimal availability of mucosa with tightly attached submucosa will lead to stress concentration. So the ultimate result is that tissues can become tolerable to dentures. Necessity for retaining maxillary teeth. Maxillary dentition may need it for retain prosthetics. This situation is usually associated with congenital degust, cleft palate, or stoma resulting from surgical or accidental trauma. Mental trauma. Some patients become depressed with the loss of teeth. This depression may lead to more complicated physiological problems. Removal of remaining maxillary teeth, even if indicated, has to be carefully analyzed and retained. Single complete maxillary denture to oppose natural mandibular teeth. Most frequently encountered problems: malposed, pupilled, and supra-erupted teeth in lower arch, and unfavorable plane of occlusion. Position of one mandibular anterior teeth, reposition, alteration. According to Sherry, if there is class 2 jaw relation, a complete denture often may be constructed against lower anterior teeth and premolars without replacing molars. Force directed by middle posterior part of upper denture. But at class 3 jaw relation situation is different because mandibular premolars would apply occlusal forces against the anterior part of the maxillary ridge, force against the anterior part of the maxillary ridge. Complete maxillary denture to oppose a partially edentulous mandibular arch with fixed prosthetics. The following points must be evaluated for the proper diagnosis and treatment planning. It must be determined whether fixed restorations are possible. If any fixed partial denture is acceptable, then the occlusal concept based on which it is going to be constructed. Composition of the artificial teeth to be used if the fixed partial denture have porcelain occlusal, then porcelain resin teeth, enamel gold resin teeth. Complete maxillary denture to oppose a partially edentulous arch and a removable partial denture. Remaining mandibular teeth should be in an acceptable state of dental health. The partial denture should meet minimal acceptable requirements. The occlusal plane to the arrangement for occlusion, aesthetics and the material composition of the removable partial denture should be suitable to be opposed by a complete denture. It is always wise to construct both the removable partial denture and complete denture at the same time. Single complete denture opposing an existing denture. The following questions have to be analyzed before giving a single complete denture opposing an existing denture. How long has the existing denture been in use? Was the denture an immediate insertion at the time of tooth removal? Does the denture meet the requirements of an acceptable denture? Has the denture opposed another complete denture, a partially edentulous arch that support a removable partial denture, restored natural teeth, a fixed partial denture? Is the operator satisfied to institute complete denture procedures utilizing the existing denture? Problem associated with single complete denture: occlusal forces, occlusal form of the natural teeth, support of the denture base, supraerupted and tital teeth. These factors causes occurrence of single denture syndrome, loss of tightening denture, a damage of mucosa, ridge resorption. Common occlusal disharmonies and ways to adjust them: titled molars with distal halves supraerupted, steeply inclined occlusal surfaces tend to drive denture forward when brought into centric occlusion. Only contact is on the distal half of lower molar in protrusive and lateral excursions. Denture easily dislodged during functional movements. Adjustment for titled molar, if molars are not severally tiled, can be reshaped by selective grinding. If more tooth structure is needed to be removed, restored with crown and or fixed partial denture. If large space exists mesial to titled molar, PD restore the mesial half of the molars, lower the distal cusps, mesial half only, mesial rest or extended rest. orthodontic repositioning of tilted molars, if severely tilted and supra-erupted extraction. Natural lower cuspids and incisors are supra-erupted, selective grinding. Canine region occlusal adjustment should aim at providing a definite distal slope on the lower canine so as to allow space for free passage of the upper artificial canine between the lower canine and first premolar in lateral movements. Mouth preparation. It's essential to obtain the occlusion and articulation that is desired. Indications: malpose teeth, several type teeth, supraerupted teeth, irregular occlusal plane, less space for teeth. Methods to achieve harmonious balanced occlusion. Functional chew-in techniques, articular equilibration techniques. Functional chew-in technique, most accurate method of recording occlusal patterns. To obtain functional chew-in technique, record basis should have good stability, patient should have good neuromuscular control, mental competence to effectively cooperate it. Functional chew-in technique, Stansbury technique, Witch technique, Shari technique, root technique. A Stansbury technique for upper complete denture opposing lower natural teeth, compound maxillary occlusal rim trimmed vocally and lingually so that occlusion is free in lateral excursions. Carding wax at buccally and lingually and patient instructed to perform chewing movements. Carding wax get functionally molded, whereas the compound rim as a central fossa maintains the BD. The generated occlusal rim is removed from the mouth and stone is vibrated into the wax path of the cusps, and this record is secured to the lower member of the articulator. The denture teeth are first set to the lower cast of the patient's teeth. After aesthetics approved at try-in lower cast chew and in record is secured and all the interfering spots and ground. Thus in centric and eccentric movements maximum balanced occlusion is established. Biggs technique, modified functional chewing and impression technique. Anterior teeth are set chair side, wax occlusal rims posterior to the cuspid teeth are removed. Acrylic resin is added and firmly pressed against the occlusal surface of the teeth on the mandibular cast. When set, acrylic resin is trimmed so as to leave only a fin of resin falling into the central grooves of the lower posterior teeth to maintain the vertical dimension. The base is then inserted into the mouth for cusp and sulcus analysis. The fin is then built up with a soft wax and with resilient liner on the teeth side. Final pass in is recorded. The teeth are then set against the recorded chew in cast and interference are ground to obtain a smooth harmonious. Shari technique, simple technique of using a maxillary rim of softened wax. Lateral and protrusive chewing movements are made so that wax is abraded, generating the final passes of the lower cusps, continued until the correct VD is achieved. Root technique suggests a technique similar to Stansbury's but suggests using two maxillary bases, one for recording the general path and the other for setting the teeth. Advantage: decreases the number of appointments necessary for the construction of the upper denture. Articulator equilibration techniques. Upper cast mounted on the articulator using a face bow with an orbital pointer. The lower cast is related to the upper by centric intraocclusal record at an acceptable VD. The bucolingual position of the teeth and their relation to the upper arch is studied. Cusp-fossa relationship of the teeth is essential. At the time of wax trying, eccentric records made and condylar inclinations are set and posterior teeth are now balanced. After denture is processed, the centric holding cusps are achieved by selective grinding and then centric balance is achieved. However, perfectly balanced occlusion in all eccentric positions may not be possible in many cases when working with natural teeth in one arch. Teeth selection. Porcelain advantages: maintain VD, wears very slowly. Disadvantages: fracture and chipping of natural teeth, difficult to equilibrate, cannot be used in decreased interocclusal distance. Acrylic resin. Advantage: doesn't wear opposing natural teeth, easy to equilibrate. Disadvantage: loss of VD, wears fast. Gold occlusals. Advantage: best to oppose natural teeth. Disadvantage: expensive, time consuming. Acrylic resin with amalgam stops. Advantage: reduced occlusal wear of resin teeth, less expensive than gold. Facilitates the final stages of occlusal adjustment procedure. After the acrylic teeth have been balanced, occlusal preparations are made in the acrylic teeth, extending to include as much of the articulating paper tracing as possible. Amalgam is condensed into the preparations and the articulator is gently closed, going side to side and back and forth until the incisal guide pin is again flush with the table. Thus the centric holding areas as well as some of the excursions are recorded in amalgam by the articulator that has been programmed to closely simulate the patient's jaw movements. IPN resin consists of an infolded, highly cross-linked interpenetrating polymer network, prevents excessive wearing of artificial teeth, minimizes the disadvantage of acrylic resin teeth and porcelain. Potential adverse treatment outcomes. Most common adverse sequelae are Kelly's combination syndrome, denture fracture, tooth wear. Kelly's combination syndrome, series of destructive changes occurring in the jaws of the patients wearing a complete maxillary denture opposed by a mandibular distal extension partial denture, has been described as combination syndrome by Kelly. Description of features. Kelly put forward 5 features of combination syndrome: loss of bone in anterior maxilla and subsequent replacement with flabby fibrous teeth, down growth of the tuberosities, papillary hyperplasia of the palate, lower incisors supraeruption, bone loss under the removable prosthetics. Saunders et al. Added 6 more additional features: loss of vertical dimension, occlusal plane discrepancy, anterior spatial repositioning of the mandible, loss of stability and refabrication of the existing dentures, epulis fissuratum, periodontal problems of the remaining teeth. Combination syndrome. Mechanics. Kelly. Bone loss is the anterior maxilla is the first to occur. Saunders. Bone loss under the removable prosthetics was the root cause for the problem. Systemic and dental considerations. Systemic factors. Diabetes or osteoporosis increase the rate of the resorption of the bone. Dental factors. In case of class 3 jaw relationships, there will be increased pressure in the anterior maxilla. When lower anteriors are retained for a long time, the patient is accustomed to bite in the anterior region. Presence of parafunctional habits increases bone resorption. Type of occlusal scheme also has direct effect on the development of the syndrome. Rational. Prevention of rapid resorption of the bone under the removable prosthetics. Prevention of exercise load in the anterior region, providing stable occlusal scheme, allowing anterior teeth only for prosthetics and phonetics and aesthetics, education of the patient. Treatment planning. Treatment planning plays an important role in the prevention and management of the combination syndrome. Prevention. Retain weaker posterior teeth by using combined endodontic and periodontic techniques. Endosseous endodontic implants are used in the posterior mandibular region. An overlay denture on the lower may avoid the combination syndrome. Modifications in removable partial denture and complete dentures. Kelly advocated covering of retromolar pack to have stability of the lower removable partial denture. Schmidt advocated construction of lower removable partial denture first and then to construct the upper complete denture. Choice of occlusion. Anterior teeth only for aesthetics and phonetics. Posterior occlusion free of supracontacts during centric and eccentric positions. During protruding movement, there should be minimum contact in the anterior region when posterior teeth are in contact. Immediate denture. Contents. Treatment plan, cast modification, surgical templates, wax contouring, flasking and boil out, processing and finishing, surgery and immediate denture insertion, postoperative care, conclusion, references. Introduction. For the patients facing the loss of all his or her remaining natural teeth, there are 4 treatment options. Options 1. One is for the patients to have all remaining teeth extracted and wait for 6 to 8 months for the extraction sites to heal. The complete denture is made following healing. Introduction. Options 2 is to convert an existing RPD into an interim complete denture. Option 3 is to make a conventional immediate complete denture. Options 4 to place implants and fabricate dentures, or if some teeth are healthy, can be used as to make overdenture. Introduction. Immediate dentures are more challenging to make than routine dentures for both the dentist and the patient. Immediate dentures may be single immediate dentures or maxillary and mandibular immediate dentures in the same patient. The latter should be made together to ensure optimal aesthetic and occlusal relationship. Classification of immediate dentures. 2 types. Conventional classic immediate dentures, CID, interim transitional or non-traditional immediate dentures (IID). Classification of immediate dentures. Artrand Lavera and Artrand Kroll describe the classification of immediate dentures as conventional and transitional, labial flank, we see no labial flank, flankless immediate dentures, partial flank. Definitions of immediate denture. Any removable denture prosthetic fabricated for placement immediately following the removal or natural teeth tooth. An immediate complete denture is a dental prosthesis constructed to replace the lost structure and associated structure of the maxillary or mandible and inserted immediately following removal and remaining teeth. An immediate complete denture may replace on one tooth or all 16 teeth in either the maxillary or the mandibular arch or in both arches. Interim prosthetics. The prosthetics designed to enrich aesthetics, stabilization and or function for a limited period of time, after which it is replaced by a definitive prosthetics. Intermediate denture. A removable dental prosthetics designed to change aesthetic stabilization and or function for a limited period of time, after which it is to be replaced by a definitive prosthetics. Classical flank type. Anterior alveoloplasty is planned for improvement of appearance, use of surgical template, need for relining or rebasing may not occur as soon as it might with other types of immediate dentures. It will occur sometime. Useful impression technique has been described by a component for construction. Labial flank disadvantage, poor aesthetic value, source of irritation to the teeth. Labial flank advantages, aids stability of the denture, healing of the tissues. The labial flank is made very thin to avoid fullness of the lip and present the desired aesthetic effect. Labial flank type immediate denture. Indications: bony undercuts no present, the lip line and lip activity are normal, the teeth are periodontally involved and the supporting bone is lost. Contraindications: pronounced undercuts are present, fullness of lip would produce an anesthetic result. Partial flank. As resorption take place, the flank is extended with co-curing acrylic resin placed directly in the mouth for maintaining proper aesthetic and healing. Alveolectomies are not needed. Very little irritation is expected. Partial flank type immediate denture. Indications: undercuts are present on the labial and buccal section of residual ridge. It's desirable the flank serve as a surgical splint. Contraindications: economic condition of the patient renders multiple corrective procedures impractical. Unusual active lip line. Flankless immediate dentures, socketed dentures, easy to construct and insert. Major problems of retention, adhesive is required. No surgical template is needed. Flankless immediate dentures, socketed dentures. Insertion is no problem because procedure involve removable and remaining teeth. No alveoloplasty is performed, so less postoperative discomfort. Flankless immediate dentures, socketed dentures, about 8 weeks after extraction, a second denture with conventional flanks should be made. After months when residual reach has changed enough to make the first denture loss, the first denture should be rebased. The patient has two dentures, one for wear and one for spare. Flankless immediate dentures indications: when deep undercuts of the anterior and buccal residual reach a high lip line and an active lip that would expose an anesthetic flank, minimal amount of surgery is desirable. Contraindications: substantial amount of both bone loss, uneven contour of anterior residual reach. Major difference between conventional and interim immediate denture, practically speaking. The CID is usually selected when only anterior teeth remain or if the patient is willing to have the posterior teeth extracted before immediate denture procedure begins. Major difference between conventional and interim immediate denture, practically speaking. The IID is indicated when both anterior and posterior teeth are to be extracted at the same time and immediate denture are provided. New complete dentures are again fabricated after the healing period. CID, IID. CID, IID indications. CID, IID. Disadvantage. Advantage of any immediate dentures: maintenance of patient's appearance as they aren't without teeth even for one day. Advantage of any immediate dentures: bandage or dressing effect that the prosthetics offer to the ones of extraction and alveolectomy. This bandage effect tends to control hemorrhage, to prevent a large measure of outside contamination of the wounds, and to maintain drugs or other therapeutic agents at the site of the wounds. Advantage of any immediate dentures: less postoperative pain as extraction site is protected. Some authors have discussed about reduced RRM. Vertical dimension, jaw relationship, muscle tone, face height and tongue position is maintained. The tongue will not spread out as a result of tooth loss. Advantage of any immediate dentures: it is easier to duplicate if desired, the natural tooth shape and position, plus arch form and width. If desired, the horizontal and vertical positions of the anterior teeth can be more accurately replaced. The patient is likely to adapt more easily to dentures at the same time that recovery from surgery is progressing. Speech and mastication are rarely compromised and nutrition is maintained. Advantage of any immediate dentures: the availability of teeth conditioning material allows for considerable versatility in the correction and refinement of the denture fitting surface, both at the insertion stage and at subsequent appointments. Overall, the patient physiological and social well-being is preserved. The most compelling reasons for the ID prescription are that a patient does not have go without teeth and there is no interruption of an normal lifestyle of smiling, talking, eating, and socializing. Disadvantage of any immediate dentures. The anterior ridge undercut, often severe, that is caused by the presence of remaining posterior teeth might interfere with the impression procedures and therefore preclude also capturing a posteriorly located undercut, which is important for retention. Disadvantages of any immediate dentures. The presence of different number of remaining teeth in various locations, anterior, posterior, or both, frequently leads to recording incorrectly the centric relation position or planning improperly the appropriate video. An occlusal adjustment or even selected pretreatment extractions may be needed to make accurate record as a proper video. The advantage of any immediate dentures. The inability to accomplish a denture tooth try in advance of extraction precludes knowing what the dentures will actually look like on the day of insertion. Careful planning apparatus experience, attention to details of the technique and explanation to the patients best address this inherent problem. Because this is more difficult and demanding procedure, more chair time, additional appointments, and therefore increased costs are inevitable. The advantage of any immediate dentures. Functional activities are likely to be impaired, however, this is a temporary impairment. Indications. Patient is socially active, good health, valuable time, and can afford multi-pipe visits, periodontally compromised teeth. Contraindications. Emotionally disturbed individuals with physiological disorders, poor surgical risk because of cardiac disturbance, endocrine disturbance, systemic conditions that affect blood clotting, post-irradiation of the head and neck regions. Contraindications. Uncooperative patients, patients with acute periapical and periodontal pathogenesis, patients who have extensive bone loss adjacent to remaining teeth, patient with poor general health or deliberating diseases. Diagnosis and treatment planning. Diagnosis and treatment planning. Diagnosis and treatment planning. Diagnostic procedures. The diagnostic procedures are divided into two phases: patient examination, consultation, interview. Patient examination. The examination of the patient should include findings of local and systemic status, accurately articulated cast, appraisal of any existing prosthetics, consultation, interview, past dental history, existing systemic conditions. Diagnosis and treatment planning. Past dental history, hemorrhagic tendencies, excessive swelling, excessive post-operative pain, allergic reaction to local anesthetics, tooth modification, the occlusal plane, eliminate prematurities in centric relation. Diagnosis and treatment planning. What type of immediate denture should be prescribed? Explanation to the patient, informed consent, examination. Explanation to the patient. They don't fit as well as complete dentures. They may require temporary cleaning or use of adhesives. They will cause discomfort. The pain of the extractions, in addition sore spots of the immediate denture, will make the first week or two after insertion difficult. It will be difficult to eat and speak, initially almost like learning to speak and eat all over again. Explanation to the patient. Aesthetics may be unpredictable as anterior try-in is not possible. The appearance may be unpredictable from what you and dentist has expected. Many other dental factors are unpredictable, such as gagging tendency, increased salivation, different chewing sounds, and facial contour. Explanation for to the patient. It may be difficult to insert the immediate denture on first day. Every effort may be done to do so. If it is not possible, it will be inserted or remade as soon as possible. Immediate denture should be worn for first 24 hours without being removed by the patient. The dentist will remove it after 24 hours. Because supporting changes are unpredictable, immediate dentures may loosen up during 1 to 2 years. The patient is responsible for or involved in refitting or relining the denture. Examination. Procedures. First extraction, surgical visit. First extraction, surgical visit. Primary impression and diagnostic tests. Elastomeric or alginate impression materials. The impression should be free of voids and should record the full extensions planned for the denture prosthetics. These impressions are poured in stone and used to make custom trays for the final impressions. If an IID is planned, preliminary impressions and casts will contain all of remaining teeth, and if a CID is planned, those will contain only anterior teeth. Protection of loose teeth from extraction during preliminary and final impression procedures for immediate dentures. Blocking out by wax, lubricating medium to the teeth, placing a vacuum-formed plastic over the teeth by placing loose-fitting copper bands over the extremely mobile teeth. Border molded custom impression tray and elastomeric impression material. An elastomeric impression made in a border molded custom impression tray. Custom trays. Type 1 single arch custom impression tray. Type 2 two tray or sectional custom impression tray. And the combination impression, the convaginal combination impression. The convaginal combination impression and the same combination impression. Maxillomandibular relation record. Identical to those for complete dentures, the remaining teeth and anatomic landmarks such as retromolar pad can serve as a guide to the height of the rim. maxillomandibular relation record in an evaluation of patient existing vertical dimension in accomplished. A Facebook transfer and record of centric relation are made. The casts are mounted on the articulators. Set the posterior teeth in centric occlusion. The trial denture bases are tried in the mouth and used to verify vertical dimension of occlusion and centric relation record as with complete dentures, followed by arrangement of anterior teeth. Now it is important to take time with the patient to record various landmarks and to put the patient's aesthetic desires as follows. Midline or newly selected midline is recorded. The anterior plane of occlusion using the interpupillary line as a guide is determined and marked on the cast. High lip line should be determined. Decision of placement of diastema, rotated teeth, notch, and other natural arrangement should occur. The existing anterior vertical and horizontal overlap should be noted. A discussion can then occur with patient as to the display of tooth, gingiva that will be attempted, or the need for a localized anterior alveolectomy if too much tooth gingival display is unspated. The casts and land area are marked with all the information gathered above, which should include pocket depths, free gingival margins, a line marking this interproximal of each tooth. The tooth selection is confirmed with the patient. When tooth is extracted, this teeth supported gingival tooth collapse into region of alveolus. Therefore, it's necessary to trim the cast for every immediate denture if the denture base is to be in close adaptation to the ridge at the time of insertion. Cast modification. Most well-known methods are standard, Gerby, and spartum modeling. Standard cast modification technique. Standard cast modification technique. Gerby's cast modification technique. Gerby's cast modification technique. The same Gerby's cast modification technique scheme. Cast modification technique. Drawback. The first, primary binding sites. The second, secondary binding sites. Binding and time of prosthetics insertion occurs most commonly at facial and interproximal surfaces. Binding and lingual aspect occur less often. Surgical template. Surgical template. Surgical template should be transparent, 2 mm thick to provide rigidity and uniform transparency, able to securely sit it in the mouth. Surgical template is fabricated by following procedure. Make on irreversible hydrocolloid alginate impression of the edentulous ridge after the cast has been trimmed and boiled out. Pour the impression in stone. Surgical template. 4 methods. Vacuum pour methods. Sprinkle on technique. Light cured clear material. Process template in clear acrylic resin. Created by waxing up, blasting and heat processing. Surgical template. Advantages. Areas of binding were clearly identified by blanching of the underlying soft tissues. Clinicians used the information to guide osseous recontouring at the time of tooth removal. This allowed improved seating of the associated immediate denture and minimized damage to the soft tissues. Surgical template disadvantage. Modifications were performed at the expense of valuable osseous tissues. Cast modification based on spectral modeling. Cast modification based on spectral modeling. The scheme. Next scheme. So next scheme. Ranging of anterior teeth. Wax contouring, flattening and boil out. And then processing and finishing. The immediate denture are processed and finished in the usual manner at complete dentures. Both the immediate denture and the surgical template should be placed in chemical sterilizing solution in a bag for delivery. Surgery and immediate denture insertion. During extraction of the remaining teeth, should take care to preserve the labial plate of bone. Usually no bone trimming is done. The surgical template is used as a guide to ensure that the prescribed bone trimming is done adequately. The template should fit and be in contact with all teeth surfaces. Surgery and immediate denture insertion. Not inadequately trimmed areas planned for bone reduction will blanch from the pressure and be seen through the clear template. The template is removed and the bone or soft teeth trimmed until the template sits uniformly on completely. This indicated that the denture will sit as it was originally intended to ensure proper occlusions and minimally induct discomfort. Surgery and immediate denture insertion. Surgery are placed where necessary. If the overdenture abutment must be reduced after the extractions, the extraction sockets can be protected during preparation by covering them with beryl foil. Surgery and immediate denture insertion. Immediate dentures should be disinfected prior to the placement. Pressure areas inside the denture indicated by rocking can be located with pressure indicating passed and trimmed. Surgery and immediate denture insertion. If occlusion isn't correct, the denture should be rechecked for seating, particularly distances, so-called heel areas. When occlusal prematurities are verified, a quick occlusal correction is done to allow simultaneous bilateral contacts. Surgery and immediate denture insertion. If immediate denture will be found inadequate retentive, a teeth conditioning liner can be placed at this stage, but the material shouldn't allow to get into the extraction sites. Berlioz foil can be used to cover the extraction sites for this procedure. Post-operative care and patient instructions. Instructions for the patient are discussed throughout the treatment and reviewed carefully at the placement appointment. The first 24 hours. The patient is instructed not to remove the denture from the mouth during first 24 hours. Patients should avoid rinsing, avoid drinking hot liquid or alcohol. Diet for the first 24 hours should be liquid or soft. Postoperative care and patient instructions. The following should occur at the 24 hours visit. Ask the patients where they feel sore, remove the denture and wash it. Postoperative care and patient instruction. Quickly check the teeth for sore spots related to the denture. These will appear as strawberry red spots. Usually these are included canine implants, lateral to tuberocytes, and retromylohyoid undercuts. Adjust any gross occlusal discrepancy in centric relation or excursions. Reevaluate the denture for retention. Place a teeth conditioner if retention is unsatisfactory. First post-operative week. Counsel the patient to continue to wear the immediate denture at night for 7 days after extraction or until swelling reduction. This ensures that a recurrence of nocturnal swelling will not preclude reinserting in the morning. Starting immediately after 24 hours visit, the patient should be shown how to remove the denture after eating to clean it and to rinse the mouth at least 3 to 4 times daily to keep the extraction sites clean. The denture should be reinserted and worn continuously. After 1 week, suture can be removed and the patient can begin removing the denture at night. Further follow-up care. After 2 weeks, remount casts are poured. The maxillary denture is related to its semi-adjustable articulator using the remount matrix made before lasting. A centric relation record is used to remount the mandibular denture and refinement of occlusion is performed. Denture line. The changes occur in ridge contour as the result of initial healing of the soft tissues and also bone have defined effect on feet of the denture. Several relines may be required during the first 8 or 12 months following the removal of the natural teeth. Soft relines liners should be used as it promotes healing due to cushioning effect. Converting RPD into immediate denture. Conclusion. Immediate denture are an important treatment modality as they provide instant aesthetics and function to the patient after extraction of all the natural teeth. More importantly, they provide a physiological support to the patient at the time of this debilitating loss. It is time consuming and expensive, and patients should also understand the limitation of this service. Overdenture. Introduction. Extraction of teeth is followed by continuous rich resorption and poor denture foundation. Loss of periodontal receptors responsible for proper masticatory function and accurate jaw movements. Retention of few remaining teeth will preserve alveolar bone and preserve periodontal receptors. Definition. A removable partial denture or complete denture that covers and rests one or more remaining natural teeth, the root of natural teeth and or dental implants. 2. Supported denture, overlaid denture, onlay denture, inlay denture, telescopic denture, superimposed prosthetics, hybrid denture, biological denture, coping prosthetics. Rationale for overdenture. Logical basic. The roots of the tooth offer the best available support for occlusal forces. Accelerated rate of bone resorption is prevented. It increases the manipulative skills in handling the denture. Periodontal membrane is preserved. Thus, proprioceptive impulses, part of myofascial complex, are retained. Occlusal forces are transmitted on oblique fibers and displayed and as tension resulting in osteoblastic response. Physiologic basis for overdentures. Sensory input from periodontal receptors, alveolar bone preservation, occlusal forces substantially increased, masticatory performance, tooth mobility greatly reduced. History. Advantages. Physiological advantage for the overdenture patients. I still have some of my own teeth If the teeth are lost later due to caries, the transition and adaptation to complete dentures has been made more gradually. Disadvantages: indications, contraindications, classification. According to method of abutment preparation. Our denture: tooth supported, implant supported, non-coping, coping, attachment. Coping: short, long. Attachment: stud, bar, magnets. Based on type of overdenture: immediate, remote, permanent denture, transitional denture, interrupt denture. Immediate overdenture: constructed prior to preparation and ready for insertion after preparation and reduction. It enhances patient's ability and adaptability to wear dentures. Interim overdenture: used for patient in transition or preparation phase until permanent overdenture constructed. Patient old partial denture can be modified and used by extending the denture and add new artificial teeth using self-cure acrylic resin. Remote of definitive overdenture: conventional complete overdenture constructed over one or more abutment teeth could be made entirely of acrylic resin or in conjunction with metal bases. Non-coping abutment: selected tooth abutments are reduced to a coronal height of 2 to 3 mm and then contoured to a convex or dome-shaped surface. Most teeth required endodontic therapy and in final step are prepared conservatively to receive an amalgam or composite type restoration. Advantages: least expensive option, more amenable to treatment, retreatment and modification in continually situations, greater degree of flexibility in formulating treatment plan. Abutment with coping: coping is cover for the exposed tooth surface. Cast metal coping with a dome-shaped surface and the chamber finish line at the gingival margin are fabricated and cemented. Short coping, long coping. Short cast coping: short coping are 2 and 3 mm and normally require endodontic therapy because the required coronal root reduction would expose the pulp. Long cast coping: long cast coping are normally 5 or 8 mm long. Conservative reduction of coronal tooth structure is done. The end result is long ellipsoidal shaped coronal cupping and a large crown root ratio. Consequently, long cast coping require a greater level of osseous support. Long coping, thimble coping. Abutment with attachments. Requirements for the attachments. Patients should have a low caries index, perform proper home care, sound periodontal health, proper bone support. Disadvantage of attachments: added time, expensive, difficult to construct, repair is difficult, requires careful manipulation by the patient, not recommended for mentally and physically handicapped. Rigid attachment and resilient attachment. Stud attachment. Simplest of all attachments. Consists of two parts: the stud and the housing. Extraradicular stud attachment. Here bir anchor. Roterman attachment. Here attachment. Other attachments of importance: microfix attachment, intrafix attachment, Schubega attachment, and quinonal attachment. Intraradicular stud attachment. The stud is attached to the fitting surface of the denture and the housing is incorporated in the abutment, zest anchor. Zest anchor system. Main sleeve is cemented in a post space made within the boot. Male portion consists of nylon. Advantage and disadvantage. Bar attachment. Bar units. Bar joints. Bar attachments of importance. And magnetic attachment. Small, strong mini magnets. One of pulse cemented in the prepared cavity in endodontically treated abutment and the other attached by to denture base.